Okay, I think we're ready to start. Hello and welcome everybody at this inaugural webinar from Ortho NorCal, your primary orthopedic and spine provider of the South Bay area. My name is Leah Rutinov. I'm the marketing coordinator of Ortho NorCal, and I am honored at hosting this event together with Dr. Jeffrey Koh and Dr. Tina Malamfi. Before we begin, a few housekeeping rules. Please mute your microphone as well as your video as a participant so the presentations you are about to hear are flawless. Additionally, when you look at the bottom of your screen, you will see a small Q&A button that you can click on to direct questions to all panelists. Those will be directed to them during the question and answer session at the end of both presentations. The presentations that each physician has prepared specifically for today is geared primarily towards patients and intended for patient education only. We hope you understand that it is impossible to answer specific questions about one single patient situation. So if you have detailed questions, we would encourage you to make an appointment and come into clinic or be seen via telehealth appointment. Lastly, if you have any additional questions, please email us at marketing@orthonorcal.com or call 408-412-8100. With all that being said, I'd like to welcome our first panelist, Dr. Tina Malamfi. Welcome, Dr. Malamfi.
Thank you, Leah, and thank you, Dr. Koh, for allowing us to participate today. I'm very excited to give this talk about the aging spine as it affects all of us as we go through life. So let's get started. So have you ever noticed that you're getting shorter as we get older? It seems that over the age of 40, we all start losing some height. Over the age of 60 in particular, we tend to shrink further and faster each year. So first off, let's go over some anatomy of the spine, some basics here. You have three areas of spine that we primarily address, which is the cervical, which is the upper portion, the thoracic, which has the rib cage attached, which has 12 vertebrae, and then we have the lumbar spine, which has 5 vertebrae. Down below, connected to our pelvis, is also considered part of the spine, where we have the sacrum and the coccyx. Normally, we have a curvature that goes kind of an S shape if you're looking from the side. If you look at the different anatomy of the spine, we'll see that there's a vertebral body, which is the bone. In between the bones, we have what are called the intervertebral discs. We also have the bone connecting each individual bone to the next one below it or above it, and that's called the facet joint. And then in the center of the canal, we have where the spinal cord lives. Fascinatingly, the spinal cord as a baby goes all the way down to your sacrum. But as we grow in our childhood years, it does not grow as fast as the rest of your spinal column. So primarily ends about between L1 and L2 in the spine. So when I'm doing procedures or Dr. Koh is doing surgery down here, we are not near your spinal cord. Often patients find that reassuring. Out of the holes on the sides of the spine, we have the spinal nerve roots coming out. And often those are what get affected in discal or facet arthritis. Let's go over some things that happen as we go through life. Normal disc height is great until we're about 30. Over the age of 30, your discs start losing water content. Sadly, that's because some of the collagen starts to die. With that, they become dried out. Think of a piece of paper, an antique piece of paper. It gets dried out and it can crack. And that is what degenerative disc disease is. It starts drying out. You start losing water content. When that happens, the jelly material on the inside of the disc can work its way outward and cause a disc bulge or even a disc herniation. When that happens, you lose some of the height of the disc and you end up with a narrowed space between the bones. That in itself will narrow the hole where the nerve exits out. Now, degenerative disc disease can be accelerated by lifting, smoking, genetically you can be predisposed to that, or if you're carrying around some extra weight, you're putting more pressure on your discs. And obviously, as we age, they're predisposed to degenerative disc disease. Here's a good model of what happens with our aging spine as well. Along with the degenerative disc disease, when the discs dry out, your joints take on more of the weight bearing. So as we get into our latter decades, a lot of what we treat is the arthritis of the joint, either causing pain itself or narrowing the hole where the nerve exits out, or if the joint becomes, sometimes it fractures just with age, that vertebra here can slip forward on the one below it, narrowing the holes where the nerves come out. And that's called instability or spondylolisthesis, which Dr. Coe will go into. We also end up sometimes with scoliosis as we get older. Here's another pathology that we treat quite commonly called spinal stenosis. It's very common over the age of 60. Stenosis means narrowing of a canal. Here, for example, is a narrowing of the canal that is caused by three things. First is a disc bulge. Second is arthritis of the joints. And thirdly, there's a ligament that lines the back of the canal that gets thicker as we age. Most commonly, spinal stenosis happens between L4 and L5 vertebra, commonly pinching the L5 or S1 nerve roots. Spinal stenosis symptoms include pain that increases with prolonged standing and walking. And as soon as you sit down, that pain dissipates in the legs rather quickly. As I mentioned before, scoliosis is also something we encounter. It can progress fairly rapidly over the age of 60, even though it was minimal as a child or even undetected. Scoliosis itself, when you're young, is not a painful condition. What happens is as we get older and that S-shaped curve puts abnormal forces onto the joints themselves, which cause arthritis or pain in the joint, and then narrowing of the hole where the nerves come out. We also must remember that our spines are not static. They're in motion at all times. When you bend forward, you actually open up the hole where the nerve exits out and the central canal where that spinal cord lives. When you arch backwards, you narrow the holes where the nerves exit or the central canal. So what can we do about these conditions? Well, normally people first will seek treatment through their primary care physician, a physical therapist, take medications, seek chiropractic treatment or acupuncture. If those treatments fail, you primarily will get sent to somebody like me, which will consider doing a spinal injection or pain management to help you function better. Once I've tried things and unable to help a patient, I will refer patients to a surgeon to see if they're a surgical candidate. Sometimes the surgeon does the best thing that they can do. However, pain is not always completely relieved, and I may see the patient back for further management. Here's what I mean by management. Lumbar epidural. Remember where I spoke about the spinal cord ending way up here. So put that out of your mind. What I do is patients on the table face down, and I put a needle into the hole where the nerves exit out under the guidance of an X-ray machine called fluoroscopy. The biggest risk of this procedure is the risk of infection or bleeding. This can also be performed in the cervical spine under the X-ray guidance. Here's an example of a cervical epidural being performed. Yes, it is more risky because I am near your spinal cord and extreme caution is taken. Treatment of the joints. That is different. In the olden days, I used to do steroid injections into the joints, but those were very short-lived treatments. So about 10 years ago, started doing some numbing medication testing to see, we numb the nerves that go to the joints. If the patient responds, we bring them back and do it a second time to make sure it wasn't a false positive. if they respond to the numbing agent on 2 separate occasions, I perform radiofrequency. What radiofrequency is heat. I put a probe parallel to where that nerve root lives, and I heat that probe to up to 85 degrees Celsius. Essentially, you're ablating that nerve, and that nerve root dies back. It does regrow. On average, it takes approximately 11 months to regrow. So those are some of the treatment options that we have for minimally invasive procedures to help people with lower back pain. Now I'd like to have you listen to Dr. Coe about his minimally invasive procedures.
Hello, I'm Dr. Jeffrey Coe with Ortho NorCal. Thank you, Dr. Malumpi, for a fine presentation. I'll be moving on to a discussion on minimally invasive surgery options. Now, I'm not going to talk, about everything that we can do in the spine, because spine surgery is a very long and involved topic and can't be covered even in a 3 or 4 day meeting, much less a half-an-hour webinar presentation. But I'm going to talk about some limited minimally invasive cervical options and show you some examples. So why should we do minimally invasive surgery? Well, minimally invasive surgery preserves muscle attachment. We spread muscles and don't strip. It's less bleeding and therefore less pain. We use smaller incisions, sometimes using tubes to dilate through the muscle. There are other special retractors that are made specifically for the purposes of minimally invasive surgery. We'll sometimes use fluoroscopy or other technologies to navigate. And in fact, now we're starting to use robots to help us get us to exactly where we need to be. Often minimally invasive surgery is outpatient surgery or maybe just even one overnight surgery in some cases. Here's an example of a disc herniation. You can see this disc that's desiccated and dry, like Dr. Malumpi said so. On the MRI, this slices through the middle of the body, and you can see the hydration of the water. The spinal cord ends up here. These discs are relatively gray and healthy. This disc is desiccated and dried out, and you can see this disc herniation there. On this segment, you see the disc herniation right here, pressing on the nerve. This is a cross-section of the spinal canal or the spinal nerve sac, and that's a nerve budding off, and that's the other nerve budding off. These nerves kind of look like Mickey Mouse's ears, and that disc herniation is pushing on that one ear, and that's what causes the sciatic pain that goes down the leg that's associated with the disc herniation. So what you can do is I'll put a tubular retractor in, and I'll see this view under the microscope, and that's an actual picture from a real surgery where there's the disc herniation pushing on the nerve. This is a diagrammatic view that shows this disc material that's come out. That's kind of looks like crab meat under the microscope and in real life. And this is the example of the tubular retractor and how we can pull that material and take the pressure out off the nerve through an incision that's less than an inch. And that's what the scar looks like when it's all healed up. Now, if you have spinal stenosis, and spinal stenosis is that narrowing of the whole spinal canal that puts pressure on the nerves, this is another cross-sectional MRI view that shows all of the nerves crowded in right there. Here's the facet joints that Dr. Malumpi discussed. There's the disc. And then you can see after the surgery, the minimally invasive surgery, that the canal is opened up. And each one of those little dots is one of the spinal nerves inside the spinal canal. And this is kind of diagrammatically what it looks like. We can, through a small incision, drill away the bone and stay on top of the ligament that keeps us from damaging the nerves with this drill. And it kind of looks kind of dangerous, but it's actually very safe. And there's the space available. I've actually taken these 2 slides and kind of put them in the same orientation. And you can see, how we would get in there to get that decompression and make this space big like that. This is a bit, if somebody has 1-level spinal stenosis, this is basically an outpatient procedure for that. The traditional spinal stenosis surgery is to do a laminectomy, where you take away and unroof the entire part of the spine right there with either drills or biting instruments. Now we actually have an ultrasonic scalpel that allows me to make bone cuts almost like a hot knife through butter. Does the same thing through bone. And so, but the problem with the surgery is you got to strip away the muscles, and that's a lot of bleeding. From time to time, that's still necessary. If there's multi-level stenosis, it's more efficient to do it that way. Now, spondylolisthesis is the slippage of one vertebra on the other. It's a major cause of spinal stenosis because it's, imagine it like how a wire cutter works, where two circles are on the wire, and then basically one circle pulls forward. The nerves get trapped that way. Now, it doesn't come completely off like a wire cutter would, but it does put a lot of pressure on the nerves, as the back part of the spine up here puts pressure against the front part of the spine, trapping the nerves in between. And this can move back and forth. In fact, very often these spondylolistheses will completely be reduced when you lie down. So, for example, on an MRI scanner, you'll be lying down as if you're in bed, and the spondylolisthesis will reduce, and it may not be even seen on the MRI. But when we stand up and get x-rays in the office, and when we say, well, that's a relatively looking at normal MRI, and when you stand up and then you see the spondylolisthesis, you know that you have an unstable situation. Similarly, with scoliosis, you have curvature of the spine. There are many individuals that will have a mild scoliosis from their teenage years that never was even braced, much less had surgery, and it becomes very painful because the spine becomes asymmetrically loaded, and there's degeneration more on one side than the other. And so where the nerves exits, they get trapped. That's called neuroforaminal stenosis. So there's a type of minimally invasive reconstructive surgery called XLIF, which really changed my practice about 15, 20 years ago. It's a newer approach where you get to the front of the spine through the side. And small incisions can be made, typically about 1 inch to 1.5 inches, and you can get the same result as if you made a big incision in the belly and pulled all the abdominal contents partially away temporarily to get there. But you can do this at most levels in the lumbar spine, and allows us to put this spacer in that opens up the space for the nerves. Here's an example. You go right through this muscle. This is called the psoas muscle. It's spelled P-S-O-A-S. It's the muscle that moves the hip. And if we stay in front of the nerves, it's very safe to do that way. And because we preserve the ligaments in the front of the spine, and we stay away from the ligaments in the spinal canal in the back of the spine, we can get in very, very safely through this approach. I did this surgery yesterday on a really nice lady who had a spondylolisthesis, and she went home this morning with much less pain than she had going in. It's revolutionary surgery. Now, we will put these rod and screws, these scary looking pictures, are basically extensions of the screws that allow us to have small incisions like this here. And these screws, these towers come off the screws, and we can leave the rods behind. So although that looks scary in the operating room, it's actually a lot less invasive than it is with the bigger open surgery. Here's an example of a patient I saw last week that I did this surgery 2.5 years ago. You can see the slippage of the spine. You see how it makes a right angle turn. And here she is with the spacer in and the rods and screws. And she's doing very, very well. Now, this is another lady that had spondylolisthesis and spinal canal stenosis. And for a while, we were trying this procedure called an X-stop. And the X-stop is a device that goes in here and pushes the spinous processes apart to try just to give enough room for the nerve. Well, that worked at first, and she did well for about 6 months, but then it kind of migrated a little bit. It wasn't very durable. So I converted her to the XLIF, and it worked very, very well after that. So I think that's it for now. We wanted to leave plenty of time for questions. Dr. Malumphy and I are here to field your questions. And Leah, if you want to go ahead and field those to us, we'll be happy to take those.
I do have a first question for Dr. Malumphy. Where are cervical epidural procedures performed?
The patient usually will have a mild sedation, especially if they're nervous at all. That way it's a higher level of safety precaution. So it's a surgery center, and it's an outpatient procedure.
Okay, thank you. We're ready for more questions. If any of participants have any additional questions, please click the Q&A button on the bottom of your screen, and we will be happy to respond to those.
Okay, Leah, thank you very much.
I'm
for-
sorry. I'm sorry. I'm sorry. I was muted. Another question just came in. A patient is asking if we treat neck pain.
Absolutely,
Yeah, absolutely.
of course. That's what we're here for. We would love to see patients with neck pain.
Okay. Another question. Can a disc herniation go away on its own?
Absolutely. It's really interesting that you asked that question because I've had not only many patients, but a personal friend of mine who had a very large disc extrusion, is what it's called. I had sent him to the surgeon a couple of times, as well as did some epidurals on him to try to keep him from surgery. He really did not want surgery, so he waited. And about 12 months later, he wanted to go skiing. And I said, "You're crazy, you just got better." So I re-imaged him, and the herniation was essentially gone. So the body sees the big disc herniation as a foreign object. And if the patient remains comfortable enough and neurologically intact, we don't typically image them a year later, but sometimes in rare cases we will see that disc herniation sometimes is extremely smaller or gone. Because like I said, the body sees it as a foreign object and will chew it up. Any comments, Dr. Crow?
Yeah, there is actually. Disc herniations often go away. In fact, there's been two major studies about lumbar disc herniations. The first one was done by a fellow named Weber in Sweden in the 1980s. And these were randomized controlled studies of patients that had disc herniations that didn't require immediate surgery because they had paralysis or severe numbness or weakness and all of that. These were patients that were they could have surgery or not have surgery. And after they had initial round of non-operative care, the patients basically said, well, this group, and they can do this in Sweden, said this group, no surgery, this group will have surgery. And it turns out that at 1 year, the surgery patients did better. At 4 to 5 years, the surgery patients were maybe a little bit better, but it wasn't maybe statistically significant. And at 10 years, it was exactly the same. So the bottom line is this: if you can wait out a disc herniation and you can kind of get through it, as long as you don't have nerve damage and you're worried about the nerve damage, if it's just pain or maybe minor numbness that you can live with if it happens to stick around, then the disc herniation, you don't have to have surgery for a disc herniation in the low back. Now, the neck's a different issue. We can talk about that if anybody has questions about that. The other study was an attempt at a randomized control study in the US, done about a decade ago, a multi-center study called the SPORT trial. And it was a complicated study that had different things in the spine. But one of the issues was disc herniations. The problem was for Americans, you tell them that you have to do something, they don't listen. So about half the patients that enrolled the trial said, well, you can follow me, but we're not going to do what you say. The other half said, well, okay, we'll be randomized. And half of those said, after randomization, you said, I have to have surgery? Heck no, I'm not going to have surgery. So, and then the other half of that were randomized to not have surgery, I'm hurting too much, I want surgery. So the numbers were all over the map. It wasn't statistically accurate, but they did an intent to treat analysis, and they also did as treated analysis, and it turns out the results were about the same. The bottom line is, if you want to get better faster, either epidurals, and in my experience with the epidurals, there was a study done by a Dr. Rue and the radiology. He's a surgeon, but the radiology group at Washington University about a decade ago. And basically it was about a 50-50 chance that the epidural would stick enough to avoid having surgery if the patient was otherwise going to have surgery. And that's kind of a soft conclusion because you never know what they would have had if push came to the shove. But I would say that the epidurals can work well enough long-term to allow the body to heal. So a good way to treat a lumbar disc herniation, if it's not dangerous neurologically, is to have the epidural because it takes the nerve inflammation away. It doesn't make the disc herniation go away any faster, but it does make it less painful and less inflamed while the body heals.
Thank you, Dr. Ko. Another question. What is the recovery time for minimally invasive surgery?
Well, it really depends upon what we're doing precisely. For the minimally invasive disc herniation, I did the starting quarterback for San Jose State University in May, and he was playing football in August. So it's that kind of thing. I mean, similar surgery for Joe Montana was, it's about 6 weeks for somebody that's already a pretty fit individual. Now, if somebody that's already deconditioned and out of shape, and it may take 3 months to be back to normal for to go back to full athletic activities. But to be able to do just normal everyday activities, I mean, I've had patients have surgery on a Friday and go back to work doing light work on a Monday. So it can be as short as a week for just light activities. If you're doing a minimally invasive reconstruction, like the XLIF procedure, it can be very short, a week or two for light activities, but if you want to do heavy work, it's more like 6 weeks to 3 months, depending. And there are other examples, but those are the two that I talked about in the talk.
Okay, thank you, Dr. Ko. The next question is, if there is no pain at the lower part of the body, does that mean there are no spinal related problems?
I often find weakness that is unknown to the patient, and that is associated with their spinal nerve compression. Those are the fortunate people that don't have the pain. But obviously weakness is something that I worry about. I always tell patients that I care about their pain, but I care more about their function.
Thank you, Dr. Malumphy.
Yeah, let me follow up with that question. There are many patients, particularly elderly patients, that have something called spinal stenosis with neurogenic claudication. Now, that's a mouthful of language. But what that means is that for whatever reason, their legs don't work as well when they stand and walk distances. And the classic example of that is in either an elderly man or a woman who says, well, if I sit down, I have no pain. If I'm at my computer, I have no pain. If I walk around the house, I have no pain. But if I want to go out on a long walk, I just can't make it. And I have to sit down. If I sit down on a bench, I'm, for 2 or 3 minutes, I'm good to go again. And sometimes that distance is short as 50 yards. And it could be vascular disease, so you want to make sure that you have pulses in your leg. But the classic example is that the nerve pressure just doesn't have, the nerves themselves don't have enough circulation. They just don't work. Now, sometimes it's mildly painful, even very painful with buttock pain and even back pain, but it's most often manifested by just leg tiredness and weakness. And these patients will find if they go to Costco or the grocery store and lean on the cart, they can push the cart around for an hour or two where they can hardly walk without assistance for a block or so. Another example is patients will just bend slightly forward. It'll take the pressure off the nerves. So that's a classic example of where it's not all that painful, but you have inability for your nerves to work properly when you stand and walk.
Thank you, Dr. Ko. The next question is scoliosis inevitable as we age? What can we do, if anything, to prevent this disability?
Okay, so scoliosis is a multifactorial problem. There's actually 3 basic kinds of scoliosis. The rarest one is that's associated with neurologic disorders and other diseases. For example, polio, which we don't fortunately see much more, or cerebral palsy, or congenital types of scoliosis due to abnormalities of bone. Those will usually be manifest early. The other type of scoliosis, most often seen in young women, but to a lesser extent in young men, typically in teenage years, is called idiopathic scoliosis. That scoliosis is it's really a genetic problem. We've found out it's a multifactorial genetic problem. We know a lot about it, but not everything of it. We can classify it. We know how to treat it. We know most of the time it'll respond to bracing. If it doesn't, then there's a surgery that can be done to take care of that. The kind of scoliosis, however, that most adults are dealing with is either de novo or brand new degenerative scoliosis from all the degeneration that was covered so well by Dr. Malumphy, or in some cases, somebody that had a really minor idiopathic curve, and then the degeneration just kind of sets it off. The bottom line is this: there is not much you can do to correct the scoliosis short of surgery. There's not much you can do to prevent it. And there's some very, very good studies, including a study that was just published about a year ago in the Journal of Bone and Joint Surgery that says, if you have disability from scoliosis, you can control it as best as you can with exercises, medications, and injections. But if you really want to get functionally better, it takes surgery. And that's unfortunately, that's one of those situations where if you are disabled from scoliosis, then that's what it's going to take. And sometimes this is very, very major surgery. A lot of it can be done, at least in part, minimally invasively, but there's no getting around that you'll have to do that. And it's not just the scoliosis. There's something called kyphosis, or what we call now sagittal plane deformity, where you start to tip forward more and more and more, and you find in the elderly patient that and it's not inevitable, and not everybody's going to get this, it's just a subset of people that will, that you have to bend your knees and flex your hips in order to stand straight. And that kind of surgery requires sometimes taking all of the disc out and angulating the spine, or even cutting through bone directly. This is a very, very complicated surgery, and we want to make it last resort, but in some cases it is absolutely necessary. And spinal deformity surgery has come a long, long way. A lot of it can be done minimally invasively, but to cut to the chase to answer the questions, it's not inevitable in everybody, but if you have it, it has to be dealt with in some way. And in some cases, it will take surgery.
Thank you, Dr. Cohn. The next question: how long will the fusion of the discs last? Can a person with disc fusion continue to play sports after the operation?
Absolutely. Peyton Manning won a Super Bowl after he had a disc fusion in his neck. And I've returned athletes to sports with disc fusions. Most of the time in the low back, a professional level collision type sport like football or hockey, that the patients will probably retire if they've had a disc fusion. But to play golf, to do almost all activities, to skiing, horseback riding, cycling, there's absolutely no problem returning to normal activities, most normal activities that you and I would think of as normal, with a single level or even a multi-level fusion.
Thank you, Dr. Cohn. The next question: can the nerve be inflicted? Will nerve die? What will happen?
Well, there are situations where if you have a large disc herniation that's massive and it totally cuts off the blood supply of the nerve can die. And we'll typically see this patient that has a very severe painful sciatica the last maybe 12 to 24 hours, and then they have a painless foot drop. The pain goes completely away, then they have a foot drop. That's a very bad prognostic sign. And yes, the nerves can die. You can also have a massive disc herniation that pushes on the entire nerve sac that controls the nerves to the bowel and bladder. That goes by the term cauda equina syndrome, which in Latin means tail of the horse. Because when Dr. Malumfi was showing you that anatomy, all those nerves that string down off the spinal cord inside the nerve sac, when an anatomist in the early Middle Ages dissected that out, said, oh, that looks like a horse's tail. And so it was named horsetail in Latin. But that cauda equina controls all of the nerves to the bowel and bladder and sexual function. And if that dies, if you have a massive herniation in that area, that you have about 24 hours to get the pressure off to keep from having permanent nerve damage. That's one of the rare cases where spine surgery is an emergency.
Also regeneration of the nerve roots. So sometimes somebody has an acute disc herniation and a foot drop, like Dr. Cohn mentioned, and they get the pressure off of that nerve root. There will be signs on what we call electrodiagnostic testing that nerve has regenerated, and you can watch the patient progress in the rehabilitation as that nerve regenerates.
And if I'm not mistaken, Dr. Malumfi, the regeneration of a nerve is about 1 inch per month. So to get all the way down to the foot, it'd probably take a year or two. Next question.
Thank you, Dr. Malumfi. I think we're done with the questions, and we're going to finish up our webinar. I'd like to thank everyone once again for joining us today. We hope you enjoyed our webinar. If you have any additional questions, please email us at marketing@orthonorcal.com or call 408-412-8100. Have a great day, everyone. Thank you, Dr. Cohen, Dr. Malumfi, for your time.
Thank you, Leah.
Thank you, Leah.
Take care, everyone.
Have a great
Bye-bye.
Stay safe.